So, Bismillah Rahman Rahim, starting with the name of Allah Almighty. So, today we'll be discussing about low cardiac output syndrome. And I have no disclosures. The outline will going to involve brief background with definition, criteria, and new scoring, which is being introduced, the causes of low cardiac output syndrome and what to exclude, key concepts about the oxygen delivery, oxygen theft, extraction, and oxygen consumption, how to manage these patients with low cardiac output syndrome, how to manage the preload, LV afterload, RV afterload, and pulmonary hypertension, pulmonary treatment of systolic and diastolic dysfunction with non-pharmacological treatment of systolic and diastolic dysfunction, and single ventricle management, uh, and the outcome studies which are being done so far, and in conclusion in the end. Most likely, we're going to have at least 15, 20 minutes for the discussion, hopefully, and we're going to have that at the end. So low cardiac output syndrome is the leading cause of morbidity and mortality in pediatric patients after cardiac surgery. And in almost 25% of the infants who underwent arterial switch operation do develop low cardiac output syndrome, and the cardiac index which is being reported is lowest at 9 to 12 hours post-operatively. Therefore, early recognition is crucial in the initial 12 to 24 hours, and bedside nurses in that play a vital role in early recognition and reporting its insidious onset to the medical team, because if it goes unrecognized, it might advance, and things might get worse if it is picked up late. Also, it occurs secondary to the acute myocarditis and septic shock patient who do present with myocardial dysfunction, acute myocardial dysfunction, which is pretty common nowadays. So, for the definition, it is the constellation of signs and symptoms indicating inability of the heart to deliver the oxygen to tissues and other end organs, which does not meet the metabolic demand. And it is a very vague definition. And if we were going to look into the signs and symptoms, what are the signs and symptoms? The signs and symptoms for low cardiac output syndrome include tachycardia, hypertension with a narrow pulse pressure, as stroke volume is not that much generated by the heart, with a poor perfusion signs, that is cold extremities, weak pulses, slow capillary refill time, and the temperature of the peripheries are being cold with oliguria or anuria. And the laboratory evidence which is indicated is arteriovenous oxygen gradient more than 30%, with metabolic acidosis with increased waste deficit of more than 4, or increased lactate of creatinine 2 on 2 successive blood gases. So it is pretty hard in the literature to define it in terms of defining how to diagnose low cardiac output syndrome. And this is a very old criteria which has been previously used in the PRIMA-COB study, which was a very one of the hallmark study in the cardiac congenital heart disease program in 2022, when they identified the prophylactic intravenous use of milrinone in after cardiac operation, and it has shown significant reduction in the mortality and morbidity. In these, they have used the criteria of tachycardia, heart rate of greater than 180, oliguria, weak peripheral pulses, a surrogate of poor peripheral perfusion with cardiac arrest, or a difference of 30 points or more in arteriovenous mixed venous saturation, with NIRS as a surrogate for systemic venous saturation. And metabolic acidosis with increased waste deficit or a lactate level more than 2. They included at least one of the two definitions of metabolic acidosis, either waste deficit or lactate, and one other criteria, if it is present, they usually define it as LCOS. But recently, however, this is commonly used criteria which is commonly used in the literature for different studies in which they have how they have defined low cardiac output syndrome in post-cardiac surgery patients. However, another important determinant is arterial venous oxygen gradient, which is really important. And it is mainly arterial oxygen saturation, which is the saturation oxygen delivery minus the mixed venous saturation, which is the venous saturation. And normally it is been around 20 to 30%. And if it is more than 30%, definitely it is considered as one of the criteria for low cardiac output syndrome. And this is one of the key finding. One can find it out. One can do the arterial and venous blood gas in these patients, especially if the venous blood gas is being done from the from the internal jugular vein through the central venous catheter. That is considered as one of the gold standard. Although the gold standard is pulmonary artery saturation, but in these patients, if it is taken from the internal jugular, that is considered as a gold standard. And if the difference between the arterial and venous saturation, mixed venous saturation, is more than 30, it is considered as one of the earliest markers for low cardiac output syndrome. The or low mixed venous saturation. The other recently elevated, they have introduced low cardiac output syndrome score, which includes 7 criteria, 1 mark for each. That is heart rate, urine output less than 1 ml per kg, which is uricemia, and then room temperature less than 30, vasoactive inotropic support requirement in excess of minimum 1.5 max per kg per minute, volume administration greater than 30 ml per kg, decrease NAIRS measurement, which is a marker of mixed venous saturation, cerebral NAIRS less than 50% and renal NAIRS less than 75% respectively, and arterial lactate more than 2 millimole per deciliter. So we're going to discuss it in detail in the later part of the presentation, where they have compared this low cardiac output syndrome score to the different outcomes and validated it as well. Coming on to the causes of post-operative low cardiac output syndrome, it is mainly related to the inflammatory cascade, which is triggered by the cardiopulmonary bypass, leading to complement activation, endotoxin release, leukocyte and complement activation, and cytokine release, which lead to intermediate mediators, inflammatory mediators, which in turn lead to significant cascade of events leading to low cardiac output syndrome and myocardial depression. Aortic cross-clamp time leading to myocardial ischemia, especially if the aortic cross-clamp time is more than almost 80, 90 minutes, as well as bypass time more than almost 100 minutes. Nothing that is considered significant. And then hypothermia is another key element, reperfusion injury, and pericardial tamponade. All these are causes of low cardiac output syndrome. However, there is a checklist of the causes of post-operative low cardiac output syndrome, in which one need to exclude the airway dysfunction. One need to make sure that there is adequate airway, that is tube position is fine, size and patency of the tube is been adequate, child is being adequately ventilated, and there is no atelectasis, or there is no pneumothorax, or significant lung findings. There is pericardial tamponade, pulmonary hypertensive crisis, presence of arrhythmia, especially if there is a loss of AV synchrony, patient to loss 30% of the atrial kick, leading to ventricular filling, and that does lead to significant low cardiac output with tachycardia and bradycardia, and significant residual lesions like residual VSD in post-tetralogy of valve repair. AV valve regurgitation in post-AVSD repair, they have significant impact on the cardiac output in the immediate post-operative period. And electrolyte abnormalities like hypocalcemia, especially in infants, because they do not tolerate hypocalcemia pretty nicely, and because of their plasmic reticulum, which is pretty immature, and they do respond to calcium quite well. So before moving forward, we're going to discuss briefly about certain concepts which are really important while we usually manage low cardiac output syndromes. That is the concept of oxygen delivery, which is really important. It is the oxygen per unit time, oxygen which is being delivered to the tissue or organ or the entire body, and it has been the product of cardiac output and oxygen carrying capacity. Oxygen demand is being defined, that is amount of oxygen that a tissue, organ, or an entire patient would need to consume whatever the need of the body is. And although oxygen demand cannot be measured, but it's a useful concept reflecting what are the factors that can affect the oxygen delivery in terms of consumption. For example, if the patient is in respiratory distress and oxygen demands of the respiratory muscles increases, therefore, we can estimate that assisted ventilation in these patients can improve the oxygen delivery and demand matching. Oxygen depth is another key concept, that is the difference between the oxygen delivery and the estimated oxygen demand. And when there is a significant oxygen depth, that is a significant oxygen requirement by the tissue or an organ, increased oxygen delivery will increase the oxygen consumption. However, when the tissue demands are being met, that is, there is no oxygen depth, then further increase in oxygen delivery will not have significant effect on the oxygen consumption. So that is really important to understand when we look into in the next few slides the oxygen dependent and independent pathway for the oxygen delivery. Oxygen cardiac output, it is the product of heart rate and stroke volume. It is the amount of blood that is being pumped into the systemic circulation in liters per minute, and it depends on heart rate and stroke volume. And arterial oxygen carrying capacity, which does comprise of the product of two, that is a combination of two, that is the oxygen dissolved to the hemoglobin and the oxygen dissolved in the plasma. And the combination of these two comprises the oxygen delivery to the different organ and tissues. And oxygen consumption is another important concept, as we have discussed about the oxygen depth, that beyond certain point, it is oxygen, increasing the oxygen delivery will not going to increase the oxygen consumption, and it is supply independent. So it is mainly this critical point below which the oxygen delivery is really important, and one need to increase the oxygen delivery in those patients to meet that point. And in pathological state, you can see that there is a shift of normal critical point to far more away where the tissue oxygen delivery is being one need to increase in order to meet that demand. And the demand become it is not supply independent, it becomes supply dependent in pathological state. That is one need to meet that demand. Either the oxygen consumption needs to be reduced, or the oxygen delivery needs to be increased. So another important factor, as in previous slide has mentioned, it is mainly the oxygen delivery and oxygen demand, and it is the ratio of these two. If oxygen delivery is being adequate, but the oxygen demand is high, definitely the child will going to go into stress state, and will go into decrease oxygen, increase oxygen consumption, as it occurs in the fever, catabolic states, agitation, seizures, increased work of breathing, and positive inotropies. However, in those situations when the oxygen delivery is being compromised, one need to decrease the oxygen demand by keeping them sedated, providing them assisted ventilation, either non-invasive or invasive ventilation. Sometimes we need to paralyze these patients in order to decrease the oxygen demand, so that oxygen delivery, which is being compromised, is being delivered to the vital organs, and hypothermia and same is being used to decrease the oxygen demand. So oxygen extraction is another important concept, because different organs extract a different amount of oxygen, and you can see the most oxygen consumption is being by the heart, which is 70 to 80%, and brain is the next, followed by the muscles. Therefore, it is really important from that standpoint, especially if we need to cut down the if the patient is in respiratory distress, or if the patient is in and in order to cut down the oxygen extraction from the muscles, now we usually keep them paralyzed and well sedated, and to decrease the oxygen demand, and we can decrease that oxygen extraction from the blood. So this is one of the key one of the key flow chart, which is the crux of the intensive care physician, in which now whatever we do, we usually improve the oxygen delivery by improving the arterial oxygen content, or by improving the cardiac output in terms of optimizing the stroke volume and heart rate, and income. At the same time, we are decreasing the oxygen consumption and demand as well, so that we can the oxygen which is being delivered can be delivered to vital organs. So the goals of low cardiac output syndrome management, it does include, number first thing is to optimize the contractility and ventricular function. Number second thing is to improve the diastolic dysfunction, especially in those patients who does have diastolic dysfunction as it occurs in the post-op repair, or in those patients with single ventricle physiology, Fontan, and other procedures. Uh, maintain adequate preload. Maintenance of the adequate preload is really important, especially in those patients who are preload dependent, as in diastolic dysfunction patients, or in single ventricle physiology with Glenn and Fontaine. They are pretty much preload dependent. Now, reduction in the afterload is really important, especially if the left ventricular function is being pretty low, and we need to reduce the afterload in those patients to optimize the left ventricular function, improve the oxygen supply and demand, as we have discussed, and allow time for the ventricle to recover, and provide rest to the ventricles as much, and provide less work to the ventricle as much as possible. Uh, For the preload management, it is really important to assess, first of all, the preload of the patient, now, which can be measured from the right or left atrial lines. And one can use either autotransfusion by hepatic pressure, which is not usually done nowadays. And usually the passive leg rest test can be done, which is also called autotransfusion, in which one can assess the volume loading on the filling pressures. One can see the heart rate, central venous pressures, and blood pressures changes with those passive leg rest or hepatic pressure. Variation in the pulse pressure or systolic pressure with the mechanical ventilation or with the spontaneous ventilation can also be seen. And if there is a variation, that is another surrogate marker, a dynamic measure for preload measurement. And absolute values of the right and left atrial pressures, like central venous line inserted into the internal jugular going into the RA, or if there is a left atrial pressure line directly inserted into the left atrium, that can give the preload pressures. Uh, for the top repairs, children may require high right atrial filling pressures, maybe 12 to 18 due to low ventricular compliance, or loss of atrial kick as it occurs secondary, which is a jet. The most common arrhythmia seen in these patients, electional ectopic tachycardia, in which the patients usually have a retrograde atrial contraction, and patients usually lack atrial kick, which accounts for about 20 to 30% of the ventricular filling. Uh, However, on the other side, equally, it may be unwise to overfill a post-operative arterial switch procedure patient, because these patients does have left ventricular dysfunction, and overdistension of the left heart may distort the coronary anatomy, and that might be not be a good idea to do that. So, small adequates of fluids by hand while observing the patient and their cardiovascular response in terms of heart rate, blood pressure, central venous pressure, and venodilation is pretty common in these patients because on rewarming, as well as some drugs which can exacerbate the venodilation, like GTN. Preload is usually given to overcome these in these situations. In a Fontaine repair, however, which are preload dependent, and the preload may be inadequate due to poor flow in the pulmonary circuit. Left ventricular preload might be inadequate. Therefore, some in these patients, fenestrations are usually made to allow desaturated blood to bypass through left to right, right to left shunting, so that there is a beneficial. It is beneficial to systemic ventricular filling at the expense of some desaturation. Uh, it may allow the right side of the heart to blow off and improve the left ventricular preload. However, leaving an atrial connection, as it occurs in the trough repair as well, when there is when the RV is struggling, surgeons do create an AST so that it is going to blow off the right-sided pressures at the expense of some desaturation. So in those patients, one can tolerate the saturations around 85, 88 as well, and sometimes in the lower 80s as well. For the positive pressure ventilation, it usually tend to reduce the RV preload by inhibiting the venous return. And therefore, in Fontan, in trough repair, early extubation is beneficial in those patients which are right-sided preload dependent. And in situations where extubation is not feasible, it is really important to move them toward the negative pressure ventilation, or at least make them less sedated, so that they are ventilating on their own on low ventilatory setting, so that that will going to generate a negative pressure and improve the venous return in these patients. For the left ventricular afterload management, it is the reduction in the afterload which improves the cardiac output as adequate diastolic filling is maintained for the coronary perfusion. So long-term and short-acting venodilators or inodilators or positive pressure ventilation are being commonly used to reduce the left ventricular afterload. Glyceride trinitrate or sodium nitroprusside are commonly used venodilatory agents which tend to reduce the preload as well as afterload. And sodium nitroprusside is another drug which is commonly used. However, one should be cognizant of the effect of cyanide toxicity at higher doses with prolonged period. For the long-term phenoxybenzamine, captopril is most commonly used drugs now, not phenoxybenzamine. It's not there. Phentolamine for the short term, as it has very short half-life and it is used in IV from IV infusions. So fentanyl can be used, phentolamine can be used now for short term. Another important aspect about the positive pressure ventilation, as it reduces the afterload, which is often underappreciated by experienced intensivists. And in addition to reducing the oxygen demand by taking over the work of breathing, positive pressure significantly reduces the afterload. You can see it in one of the study they have in a normal individual, although increase in the non-invasive CPAP does not have effect on the left ventricular transmural pressure. But if you can see in the heart failure patients, the increase in the peak have significant effect on the left ventricular transmural pressure, and it decreases the afterload significantly. So either invasive or non-invasive, now both are pretty useful in optimizing the left ventricular afterload, that is decreasing the afterload, especially if one is dealing with left ventricular dysfunction. That is, one can think of non-invasive or invasive positive pressure ventilation. From the coming on to the right ventricular afterload and pulmonary hypertension management, post-operative pulmonary hypertension is particularly common with high preoperative pulmonary blood flow lesions like large VSDs or AVSDs, and those lesions in which there is obstruction to pulmonary venous blood flow like TAPVD. Elevated pulmonary vascular resistance can result in RV failure and poor cardiac output. And however, other condition like obstruction to right ventricular outflow tract to LVOT, which can involve left AV valve incompetence or any other lesion associated with it, will increase the right ventricular afterload. Or if there is a residual left to right shunts, that will also increase the pulmonary arterial pressures. And all these things should be kept in mind if one is seeing patients with right ventricular afterload issues. So what are the preventive strategies to prevent this afterload? One need to have optimized sedation, neuromuscular blockade, induced respiratory or metabolic alkalosis, and hyperoxygenation, which is a potent vasodilator, pulmonary vasodilator, and avoid any triggering event for the pulmonary hypertensive crisis. It is also really important, example, administering fentanyl bolus to the patients with air prior to the airway suction. That is a common protocol that we usually use in these patients. Another commonly used drug, especially for right ventricular afterload reduction in pulmonary hypertension, is inhaled nitric oxide, which is a potent endogenous vasodilator. It produces vascular relaxation via increase in intracellular concentration of guanosine 3,5-cyclophosphate monophosphate and It's a specific pulmonary vasodilator delivered directly to the alveoli. It is rapidly inactivated by hemoglobin. So, any patient who does have issues of pulmonary hemorrhage or pulmonary edema, they do have increased chances of developing pulmonary hypertension. And it does not reach the systemic vasculature, therefore it eliminates the risk of systemic hypertension, which is commonly seen in other pulmonary vasodilators like systemic pulmonary vasodilators, sildenafil, and other drugs which are commonly used. Uh, RV afterload is commonly reduced by it. It improves the RV ejection function, and in turn, it improves the pulmonary blood flow and cardiac output. Also, the relationship between the intrathoracic pressure and PVR is really important, and one need to keep in mind that it is a U-shaped curve that one need to keep it at a optimal FRC. If the patient is at the atelectasis site, there is increase in the PVR, and that will going to increase the right ventricular afterload. So, at the same time, if the patient is toward the hyperinflation side, definitely that will going to increase the pulmonary vascular resistance as well, and it will further increase the right ventricular afterload. So, if the patient is ventilated, one need to have optimal PEEP strategy and ventilation strategy to achieve the optimal FRC, and one should be at the lower side of the U curve so that one can prevent the atelectasis and hyperinflation and maintain that FRC toward optimal right ventricular afterload, so that optimal QVR is being achieved with that. Then coming on to the pharmacological treatment of systolic and diastolic dysfunction, commonly used pharmacological agents nowadays, adrenaline and adrenaline is commonly used. Dobutamine is being replaced with the milrinone most of the time, and people are being using milrinone quite often, which do act as inodilator and has a lucitropic effect as well. Apart from that, dopamine is still in low dose, sometimes used to have chronotropic and inotropic effects. And noradrenaline is commonly used, especially in patient who does have an vasodilation post-operatively. And it has been seen post-operatively that some of the patients does have some element of endothelial dysfunction leading to dysfunctional vasomotor tone, and they do require some small amount of noradrenaline is being required in these patients. Apart from that, people does use vasopressin as well. So it does depend which center you are being working. Some people prefer noradrenaline versus vasopressin, and some centers use vasopressin rather than noradrenaline. So it does depend on the center to center. In Australian and New Zealand side, the people usually use vasopressin. However, in the US side, people do use noradrenaline quite frequently. And levosimendan is being used as an inotropic effect as it is attacked at calcium channels, and it does cause this inodilate. It does have inodilator properties as well. So these are the commonly used drugs post-operatively to optimize the cardiac output in terms of systolic function, and in terms of diastolic dysfunction. For diastolic dysfunction, most commonly inodilators are being used, and for the systolic dysfunction, most likely adrenaline and plus minus dopamine is being used in these patients. And in order to control the vasomotor tone, noradrenaline and vasopressin are commonly used drugs. As per the primary corpus study, after that, milrinone is being the drug of choice, and it has shown that it significantly reduces the poor outcome in patients when high dose of milrinone was being used against a placebo versus low dose. So after that, most of the patients have shifted the gears from dopamine to milrinone. However, there is one recently randomized double-blind trial, which although in a very small population of patients have been done, almost 20. But it does not show any superiority of any of the drugs, milrinone versus dopamine. Any of the drug does not have any superiority in terms of its use. However, milrinone is now commonly used drug in most of the centers after this trial. So, thyroid hormone, there is an essential role uh, of thyroid hormone in metabolism and in maintaining hemodynamic instability. And it has been seen that there is a suppression of thyroid hormones, which is demonstrated after the post pulmonary bypass. And it is maximum between 12 to 48 hours, and sometimes it lasts up to 7 days. However, the recent systematic review does not show any benefit. But we do see sick thyroid in these patients, and we do supplement thyroxine in these patients. Ideally, T3 should be used in these patients, but as we don't have it, we usually use thyroxine in these patients, and we usually keep a track on the T4-TSH and keep them evaluated by the endocrine services in the course of the post discharge management. For the non-pharmacological treatment of systolic and diastolic dysfunction, delayed sternal closure is one of the key strategy, especially in those patients who are stage 1 normal procedures, in those patients who are on ECMO, in those patients who are having hemodynamic instability with high ionizing support, when they usually get off pump, and or they are not being able to off pump after the surgery, and or if there is a persistent bleeding and the bleeding is difficult to control, and these patients do require delayed external closure. The aim is to allow the heart to recover and become so that it will when the sternum is closed, the heart will become less edematous and delayed. However, delayed external closure is associated with its own risk of increased infection, that is mediastinitis. That's why most of the centers do give prophylactic antibiotics and patient who does have open chest, and once the chest is closed, they do de-escalate that antibiotics as well. And when the sternum is closed, one need to monitor significant hemodynamic or steady changes and should anticipate those changes accordingly and decide accordingly. Uh, Induce hypothermia to 32 to 33 degrees centigrade, and usually it is common to do it intraoperatively. It is being done routinely for the myocardial protection. However, in post-operatively, it is used in low cardiac output syndrome, especially reducing the body temperature. It results in the decrease in metabolic rate, decrease in oxygen demand, and it also decreases the heart rate. And usually decrease in temperature, we usually do it in jet and other ectopic tachycardias as well to reduce the heart rate, and that has been pretty common. A direct beneficial effect on the cardiac function, SVR is usually increased with the stroke volume, and MAP are usually maintained. However, it is not without a risk. It increases the chances of sepsis, coagulation disorders, because it causes coagulopathy, and altered pharmacokinetics of certain drugs, as well as there are electrolyte imbalances as well, like hypokalemia, phosphorus changes, and magnesium changes as well. So one need to keep a close eye. There is a separate protocol. If one is inducing hypothermia, one need to follow that protocol so that they can keep an eye while they are rewarming the patient on the potassium and other electrolytes, which are pretty important to monitor. Uh, However, when the patient is being induced hypothermia, they need to be paralyzed, because shivering, in order to prevent shivering, if the shivering is not being controlled, then it will further increase oxygen consumption and it will increase the lactate production. And the reason why the patient is being cooled will not going to make a difference, because lactate and oxygen consumption is going to increase. So one need to make sure that they are paralyzed, and one is measuring, one is preventing them to shiver. Then definitely extracorporeal life support, that is for the ongoing organ. It is really important. It allows myocardial recovery while preventing ongoing damage to the other organs. Cardiac dysfunction is potentially reversed, and one need to it is really important while putting the patient on extracorporeal life support. One need to make sure that the cardiac dysfunction to which they are putting them on ACLS, it is potentially reversible. It depends which type of support is being used. Arterial, LV or RV assist devices. However, selection and assessment of the candidates is extremely important. one need to define whether while they are being put on ECLS, they are being put for recovery, or they are being put as a bridge to transplant. And that is really important to identify. However, survival to hospital discharge is between 40 to 55% in most of the series, according to the ECLS registry reports in these cardiac patients. However, it does vary from patient to patient depending which type of surgery is being done. Then from the pacing and arrhythmias management, arrhythmias that result in a loss of AV synchrony or significant effect on the heart rate and are common in 25% of the patients and are poorly tolerated in the setting of LCOS because it will further decrease it will increase the oxygen consumption, oxygen metabolic demand of the myocardium. And oxygen consumption is being increased in the myocardium, and that will going to have a deleterious effect on the myocardium as well. And it will tachycardia usually allow inadequate time for ventricular filling, especially with a poorly combined ventricle. And if you remember that most of the left ventricular coronary perfusion is in the diastole, the more the tachycardia is, the lesser the coronary perfusion, and one need to look into it pretty seriously from the standpoint of decreasing the heart rate in these patients, so that adequate coronary perfusion is being maintained and adequate supply versus demand being maintained in these patients. Bradycardia is also poorly tolerated, particularly in neonates, especially after the switch operations. And however, it is easily overcome by the atrial pacing alone. However, by dual pacing is required if there is an issue of complete heart block or if there is AV dissociation. Non-sinus tachycardia can be more problematic. And appropriate treatment depends on the exact type of tachycardia. I'm not going to go into the detail of different tachycardias, however, jet, which is commonest arrhythmia in the setting, and the rate controlled by the temperature reduction and emetron followed by the AV sequential pacing is appropriate management. And it is AV synchrony is particularly important in the management of LCOS because of the atrial kick, as we have discussed earlier. Preload to the ventricle atrial kick contributes about 20 to 30% of the stroke volume. This is one of the commonest A-wire for the jet, in which now you can particularly see the A waves and apnea, which are coming after the P waves, and that's a very common scenario in the cardiac ICUs. So what are the consequences of the low cardiac output syndromes? That it can lead to ventilator dependency. It can lead to patient edematous, malnourished. We do have malnourished child, so that is also one of the bigger problem in our scenario, that almost more than half of the patients are malnourished as well. And that contributes to the significant morbidity, significant sedation problems, and they do have vascular access difficulties. However, much can be done to minimize the effect of alphosphena while awaiting for intrinsic myocardial contractility. And there are certain things that we can do to prevent that. For example, these patients do have acute kidney injury and fluid retention, and it is pretty common due to poor renal function and low mean blood pressure. Diuretics are usually necessary after the first 24 hours, and continuous infusion of furosemide are often preferable as compared to the boluses, as they in terms they usually tolerate continuous infusion quite well. Early peritoneal dialysis prior to the significant edema formation is really important, and it prevents the excessive fluid furosemide toxicity as well. And many surgeons routinely practice that they place the dialysis catheters in high risk infants and other operations, and that significantly lower the threshold for commencing the PD. And recent studies does show that PD was used in 20% of the cardiopulmonary bypass cases, and the risk factors for needing PD were identical to those of those who are developing LCOS as well. So one need to just make sure that it has been instituted early in the treatment, and one should start it early in order to prevent complications to happen. Then Respiratory failure in low cardiac output syndrome is usually multifactorial, and it is mainly the result of fluid overload, as uh, our patients are malnourished as well. They have muscle weakness, critical illness, polyneuropathy. They have issues of atelectasis, and especially in the infants when their airway get compromised, and upper airway edema, and intrinsic lung disease, and with significant reduction in the FRC secondary to sternotomy. Therefore, appropriate ventilation strategies in these patients is to optimize the PEEP to the level of FRC, functional residual capacity, minimize minimize the tidal volumes, usually 6 to 8 ml per kg, but one can generally give it to 8 to 10 ml per kg as well, and avoid paralysis as possible. Optimal nutrition is often difficult due to fluid restriction and gut failure. Therefore, early institution of enteral nutrition is the key, and early use of jejunal feeding strategies are really important in these patients. TPN sometimes required, but often can be avoided if we can consider jejunal feeding. And it is often worth starting PD to make significant space for increased caloric intake, so that extra fluid is being taken out by the PD, and caloric intake should be increased to optimal in these patients. So single ventricle physiology is also really important in these patients, because how do we balance an QPQS in these patients by the hematocrit manipulating the SVR and different ventilation strategies, so that we can balance the QPQS. Effect of hematocrit manipulation, you can see it with this, and although the study is pretty old, but you can significantly see the effect of resistance after the transfusion, that vascular resistance in the systemic circulation is not that much high. However, if you are going to see the pulmonary vascular resistance, that has significant effect on the pulmonary vascular resistance, as the hemoglobin or hematocrit goes higher with the transfusion. At the same time, if you're going to see the QP, as well as if you're going to see the QP after the transfusion, that is a blood flow toward the pulmonary circulation, it goes pretty low as compared to the systemic circulation. So transfusion does have significant effect on the pulmonary circulation, and one need to keep a close eye, especially those patients who are at risk for pulmonary hypertension, or who are going through pulmonary hypertensive crisis. One need to make sure that their hematocrit is on the lower side in order to optimize the in order to optimize the pulmonary blood flow in these patients. If you're going to keep it on the higher side, definitely it will going to decrease the pulmonary blood flow, increase the pulmonary vascular resistance, and you'll be in trouble in those patients. What are the effects? Different ventilation strategies, and as we know that reduced FiO2 that increases the PVR and decreases the SVR, and thus decreases the QPQS. In terms of increased CO2, it increases the PVR, decreases the SVR, and it decreases the QPQS. Reduced pH, it increases the PVR, and it decreases the SVR, and it decreases the QPQS. And for the PEEP, if we increase it, SVR after load, it is reduced, and QPQS will going to decrease. So there was an early dogma in 1990s that saturation predicts the QPQS, and keep the saturation around 75 to 85. And systemic perfusion is entirely dependent on balancing the QPQS, and QPQS should be balanced by manipulating the PVR. However, if you are going to see studies does show that there is a wide range of oxygen saturation. The QPQS is pretty wide as well, and it is wide over. So oxygen saturation does not predict the QPQS, and as well as if you are going to see the venous saturation, venous peak saturation, that is pretty common after the Norwood, and one should consider mixed venous saturation or pulmonary venous saturation measurement in those patients. That's the petrol patient measurement. So does saturation predict the QPQS? It does seems unlikely. However, another important is systemic delivery, solely dependent on balancing the QPQS in these patients. So it has been seen, if you are going to follow this graph, this is the cardiac output almost 3 mL per kg per minute. And this is a cardiac output of almost 1.5 times cardiac output, that is 450 mL per kg per minute. And if you're going to see on this side of the graph, it is QPQS less than 1, and this is QPQS more than 1. And if you can see there is as the overall cardiac output is being increased, there is a wide range of QPQS one can tolerate. And the same is true for the arteriovenous oxygen difference, and if the cardiac output is being maintained to the normal cardiac output, and if it is overall cardiac output can be improved, one can even tolerate the higher arteriovenous and oxygen difference in these patients. Afterload reduction improves the oxygen delivery. That is significant as well. If you're going to look into the SVO2 as well as AVO2 difference, that is SVO2 usually go higher, and AVO2 difference is pretty low in those patients who have significant afterload reduction. So that is pretty important in these patients. So for the management of single ventricle physiology, saturation alone is a poor predictor for the QPQS, and for the QPQS is best balanced by manipulation of the SVR rather than manipulation of the PVR. And the best way to guarantee adequate oxygen delivery is optimize the total cardiac output, that is QPQS growth, rather than just balancing between QPQS. So just briefly going through the vasoactive score and its outcome. This is one of the largest study which has been in which they have looked into DC4 consortium and VPS system registries, and they have found out that higher the vasoactive score, the poor the composite outcome in these patient is, as well as if even when they have seen vasoactive score more than 20, and multivariate analysis does show they have those patients who does have vasoactive score more than 20 in the first 24 hours, they have poor outcome for a long time to first extubation, prolonged ICU length of stay, need for reoperation, died in hospital or within 30 days of hospital discharge, cardiac arrest requiring CPR, mechanical circulatory support, neurological injury, and cardiac arrest requiring CPR or mechanical circulatory support. And the same is true when they have seen it in patient as with respect to the age, if it is they are neonates or if they are infants, and same they have seen it when they have considered a stats category of 1 to 3 or 1 to 4, they have similar experience on those. So any vasoactive score more than 20 in the first 24 hours is considered to have a very bad outcome in these patients. Another study in which they have validated and they have looked into low cardiac output syndrome score, and this is a score of 7, and when they have looked into the peak low cardiac output score in 24 hours less than 4 versus equal to or more than 4, and they have found significant those who have equal to or more than 4 of these criteria, they do have significant increased duration of mechanical ventilation. Cardiac ICU length of stay is pretty high, peak vasoactive inotropic score is high, mobility is high, and unfavorable outcome is high. However, they have also looked into another criteria, which is cumulative length LCOS score less than 7 or more than equal to 7. That is they have measured the LCOS on admission, then on 8 hours, 12 hours, and then 24 hours. And they have taken a cumulative score, and if it is less than 7 or more than 7, and they have found a similar thing in these patients as well. So this is one of the things that can be kept in mind, and you can see in your patient if LCOS is less than 4 or more than peak LCOS is less than or more than 4, score more than within 24 hours. So in conclusion, low cardiac output syndrome is a common problem in pediatric intensive care that is often predictable and sometimes preventable as well. Diagnosis relies on anticipation, clinical features, and investigation. Management is aimed at achieving the optimal balance between the oxygen delivery and oxygen consumption. Preload and afterload should be optimized prior to escalation of inotropic support, and effect of post-operational ventilation and non-pharmacological strategies should not be underestimated. And with that, I will going to stop and open to the question and answers.